You're listening to Streetside, the Street Medicine Institute Student Coalition podcast.
Hello, I'm Michael Brennan, your guest host today for Streetside, the official Street Medicine Institute Student Coalition podcast. And it is my pleasure today to introduce Dr. Margie Urban. Margie is the medical director of the Monroe County Department of Health's Sexual Health Clinic and a professor in the University of Rochester School of Medicine. Margie, welcome to Streetside.
Thanks so much, Michael. I'm happy to be here.
Yeah, well, tell us. Let's start with a bit more of an introduction. Tell me a little bit about your path into medicine and your current roles.
Okay, sure. Well, I am now an infectious disease specialist, and as you said, I'm a faculty member at the University of Rochester here in Rochester, New York. And my area of focus within infectious diseases, really for my whole career, has been sexually transmitted infections and HIV, sort of the care and prevention of those infections. So one of my roles, as you said, is as the medical director of our local sexual health clinic, and also for several years now, I think 11 years, I've been the medical director and principal investigator for what is called the New York State Clinical Education Initiative Sexual Health Center of Excellence. So that's a very long title, but really to distill it down, we abbreviate it to CEI, meaning Clinical Education Initiative. And we, with gracious funding provided by the New York State Department of Health AIDS Institute, provide clinical education to New York State providers about all aspects of sexual health.
And I believe you have a 24/7 hotline. Is that correct?
We do,
well?
For New York State.
I've used it.
New York State clinicians, actually. So it is a state program, but we do have a 1-800 number where we field clinical questions from clinicians around the state, often related to syphilis, which is a complicated STI. And now we get about 500 calls a year, really, to do education around STIs, kind of focused on whatever the clinical situation is.
Fantastic. And Margie, if I can call you that.
Of course, yes.
Yes. What I'd like to start with is a little bit of epidemiology of what's happening in the world of sexually transmitted infections. What are the trends? What are you seeing over your career?
Well, it's mostly up, really have been the epidemiologic trends. As you know, all data lags behind. So the most recent data related to STIs nationally comes out of the CDC's STI surveillance report, and we have 2023 data are the latest that we have. But for the last several years, maybe decade, we've had really steady increases in the reportable STIs, and those include syphilis, gonorrhea, and chlamydia. HIV is sort of handled separately, and we've had really record highs. 2023 was a little bit different, where we started to see a decline in some of those. So maybe we're seeing the beginning of a flip to a decline after these many years of record highs. One data point doesn't make a trend, but there's a lot of hope about that we might be flipping.
What do you attribute that to? What do you attribute?
Well, hopefully it's more testing and treatment. I hope it's a true decline. So we'll see. I think the 2024 stats will be out in not too long.
Okay. Tell me, just when we look at the epidemiology of STIs, it leads naturally to the next line of questioning, which would be harm reduction. What efforts are you making in your role for harm reduction, and what's available now that didn't used to be?
Well, that also is kind of a big question. So we've had, for many years, really three approaches to harm reduction, to avoiding STIs. So one, of course, is abstinence, right? So if you don't have sex, you don't get a sexually transmitted infection for the most part. Another would be sort of limiting your sex partners to those who don't have STIs, generally because of testing, and assuring that you yourself don't have any at the time. And then if you have a monogamous situation, you should avoid risk. And barrier precautions, so condoms, have been, touted for many, many years. There are new interventions, and I think probably the most excitement about STIs prevention has been in the last year to 2 years, and that's involved what's called doxypep. So that's when one takes doxycycline as post-exposure prophylaxis. So if there's a sexual encounter where there could be some risk of an STI, and that could potentially be every sexual encounter. If you take 200 milligrams of doxycycline within 72 hours of that sexual encounter in randomized controlled trials that look to be effective in preventing both syphilis and chlamydia pretty decidedly, and maybe preventing gonorrhea. The results there were a little bit mixed. These studies were all in among men who had sex with men, so that's really where there's proven benefit that one could extrapolate maybe, although there are not studies to support this among men who have sex with women. And there's one study that looked at the same approach that was done in Kenya, in Africa, and there taking the doxycycline did not appear to be effective at preventing the STI after sex. Though since then there have been further looks at this, and it turned out there really wasn't a lot of adherence, and so the doxycycline levels were quite low. So there's more to come, I think, on that front.
But exciting.
Very exciting.
I mean, 200 milligrams of doxycycline is not a big dose of a toxic medicine. That's very easily acquired and inexpensive and readily available. Correct?
Yes, correct. Yeah. And there are now CDC guidelines. New York State Department of Health has their own guidelines. Many other states and departments of health have issued sort of letters recommending this. You can Google it fairly easily to see the formal guidelines from CDC, or even what would be your local jurisdiction, whether it's a state or local health department. There's quite a lot of interest and chatter, if you will, about this. Actually, more editorials, I think, about doxypep than actual studies. It really has generated tremendous interest, both in the scientific and popular press.
Well, let me ask, for our sex worker population, would that be recommended? Can you take your doxy every day for extended periods of time?
Well, yeah, that's a good question. So that's a little bit of a different intervention if you're taking doxycycline every day. So what I just referred to was doxypep, so post-exposure prophylaxis, right, and between 24 and 72 hours after sex. There's another intervention also being studied known as doxyprep, so that's pre-exposure prophylaxis, and the dose in those studies is 100 milligrams daily. That was also studied in very small sort of pilot kind of projects among men who have sex with men. And there are now ongoing larger trials. So there's a lot of interest in that. There's certainly theoretical reason to believe that could work.
But the studies are pending.
The studies are pending.
Okay.
Now, with every intervention, there's a flip side, right? So the flip side is it's antibiotic use, and so there's a lot of concern about antimicrobial resistance, and so those studies are also pending. There's some data that looks like it might not be too bad, if you will, but really there's a lot more to come in this story, I think.
Okay, stay tuned.
Yes.
Yes. Well, tell us, since we're on PrEP and PEP, can you talk about HIV? PrEP and PEP?
Yeah, I can talk a little bit about that. So HIV, of course, is a virus, so a little bit different than the bacterial STIs we were just talking about. But we really have very, very well-established data that both pre-exposure prophylaxis, so taking medication either by mouth or injectable, can prevent the acquisition of HIV, or taking medication after an encounter, although this has to be done very, very quickly, can prevent acquisition of HIV. And they're really like decades ahead of doxypep that I just referred to, but very well-established interventions.
Tell me, from a primary care standpoint, what has happened over my lifetime is, from the early days of the AIDS epidemic, the band played on, San Francisco, 1980s, people dying. And I worked at a hospice house caring for those dying of HIV/AIDS. We've come to now have it be something of a chronic illness. My patients take their Biktarvy and they seem good to go. We have come light years in therapy for HIV, have we not?
Yeah. Oh, absolutely. So we are about the same age. So I also sort of came of age medically in the time of full-blown AIDS and took care of many people who were diagnosed and died within the usual life expectancy of maybe 1 to 2 years. Were diagnosed late, they had opportunistic infections. And now when we train our infectious disease fellows, for instance, they might not ever see those opportunistic infections in training because, thankfully, people's immune systems are good now with the current therapy. So there's been such amazing advances in the care of HIV to the point that really it's pretty much a normal or very close to non-HIV life expectancy. The problems tend to be the problems of aging that might be accentuated. This is sort of a hot topic in HIV areas of HIV and aging, but the crises of the opportunistic infections that arose out of having such a depressed immune system, pretty unusual now if one gets care. Yeah. So, of course, you have to know the diagnosis, and you have to get the medication, and you have to take the medication. Right. So 3 steps.
And when we're talking street medicine,
yes.
for people that are unhoused, without a phone, without transportation, those become sometimes insurmountable challenges.
Right. Yes.
Can I pivot on you quickly here to hepatitis C, another viral,
tremendous advance in a viral infection. Now, even with the advances in the beginning, it was still a little bit hard to treat, and it was complicated treatment. But now it's really pretty simple. The key again is to make the diagnosis, to get the medication, to take the medication. But then you're done. It's unlike HIV where at least to date you're on the medication, much like diabetes, for the remainder of your life. With Hep C, it's a very short course.
My understanding is you can take the therapy and then be reinfected.
That's true. Yes.
Okay. Mm-hmm. So you have to continue to test not the antibody but the viral RNA load.
Correct.
Yeah.
Correct.
Okay. So those are a couple of viral illnesses. Let's go to an ancient disease that's the scourge that is on the rise, which is syphilis.
Yeah, so syphilis is a complicated infection. So I alluded to that warm line we have, that clinical line that we have, and we get about 500 calls, and I'd say 450 of them are about syphilis. So syphilis is a very old bacterial infection. Everything about it is confusing, really. So the testing can be confusing. The how to stage, how to decide where in the course of the natural history of the illness a patient is on the moment that you see them, that can be difficult, and that determines treatment, and that determines how you manage their partner. So that's kind of a key step. So I don't know if you want to walk through that a little bit.
Yeah, could you?
Yeah,
like,
sure.
How would that? And since our listeners are street medicine clinicians mostly, or people that are interested in street medicine, how might syphilis present on the streets? Take it from that.
Well, maybe best to just talk about the natural history of syphilis, and
Sure.
you can see someone anywhere along that course, right? So the infection is an infection that's acquired through close physical contact. Doesn't actually have to be sexual intercourse, but very close contact. And the organism sort of enters the body and has a period of incubation. And that period is pretty long compared to most bacterial infections. It can actually be up to 90 days. So one could be exposed but still have negative tests and no symptoms even 3 months later. So that's your first, this is hard. But once infection is established, it's usually about 3 weeks after exposure, even though it can go out to 90 days. It starts with what has classically been called a chancre. And the chancre or an ulcer occurs wherever that infection happens. So it might be in the mouth, it might be in the vagina, it might be on the penis, it might be in the anus. You as the street medicine provider, or you as the patient, may not be able to see it, right? So it's kind of hidden, and classically it's painless. So you might have a patient say, I have a sore, or more typically, they don't notice and it heals spontaneously. The organism actually has fairly quickly disseminated through the whole body, and that initial chancre is called primary syphilis. The next stage is called secondary syphilis, and that's when that dissemination in the body can cause any number of manifestations. And that's where you get these medical phrases from when you were in school. To know syphilis is to know medicine. It's the great imitator. That's all from secondary syphilis. Classically, and what you most often would be drawn to would be rash. And that rash can be anywhere. It's often on the genitals. It often involves the palms and soles, so they can be clues to think about syphilis, but it really can be anywhere. But secondary syphilis can also do other things. It can cause a flu-like illness, so it could look very much like acute HIV infection or mono, or the flu for that matter. Muscle aches, sore throat, headache, even fever. It can cause adenopathy, even adenopathy enough that you can see it across the room. So pretty prominent adenopathy. It can cause hepatitis, nephritis, iritis, meningitis, any itis you can say it can do. So that's where you get the great imitator. But rash is the classic thing that we're taught to think about. And then another reason that syphilis becomes sort of hard to manage, it enters this period of latency where you still have positive tests, but you have no symptoms necessarily. And then you get sort of the late complications. So you could see someone who was infected with syphilis 20 years ago, never diagnosed, and now they have a complication, maybe a stroke-like syndrome that's caused by a vasculitis in the brain, or even very, very late complications like you used to see portrayed in the movies, like the dementia that can be associated with syphilis. So all, that's a big spectrum,
right.
A big spectrum. Fortunately, for the most part, the tests are positive. So if one is able to do tests, which are antibody tests for syphilis, you can detect the infection, and it's really pretty easily treated with penicillin, which was the first effective drug. If you saw some of those symptoms, that would make you concerned to do a test, but maybe doing screening tests would help prevent those late complications.
And the big question for those of us treating syphilis is, do they get one shot or three?
Right.
Comes down to that.
Yeah. So the one shot is if the infection is there for less than a year, and the 3 shots is if it could be there for more than a year. It gets a little more complicated right now because we have a national penicillin shortage, so maybe you have no shots to give.
Tell me about that. Why do we have a national shortage of penicillin?
Yeah, I don't think I can answer that. We
no,
have
without
to ask Pfizer.
Okay,
Yes.
all right. Yeah, it seems absurd that in the first antimicrobial, like why now?
Yes, there was a problem with contamination with a number of lots, and so those lots were pulled off the market. So that kind of exacerbated an already short supply.
Yeah. Okay. And our alternative for the pen allergic is doxy, is it not?
Is doxycycline. And if syphilis is present less than a year, it's 14 days of doxy given twice a day. And if it's present more than a year, it's 28 days. Okay. Can I just say one more thing, like one caveat?
Yeah.
That we have been seeing in this kind of surge of syphilis in the recent years, quite a large number of cases with neurologic involvement, particularly with ocular involvement or otic involvement. So it's really important if one diagnoses syphilis to do an interview and say, are you having any visual symptoms? What about ringing in the ears or hearing loss or even balance problems? Because they can be indicators that there's neurologic involvement with syphilis, and that requires a different course of treatment. It would really need IV therapy.
What I'm thinking about from my perspective as a street level primary care provider is the critical importance of testing. You're not going to treat these infections unless you know they exist, and pushing that treatment out onto the streets, and getting the blood, getting the urine, and testing for STIs is critically important. Have we seen advances in our testing methodologies?
We have. We now have. Particular to street medicine maybe is the availability of point-of-care tests for syphilis and for some other STIs, but syphilis in particular. There are 2 point-of-care tests that are available, one that tests just for syphilis and one that tests in the same test syphilis and HIV. So that is an advancement. There's now an FDA approval for an over-the-counter syphilis test that could be purchased by a layperson, not a healthcare provider, and maybe not so relevant to street medicine, but there's any number of online options that if you Google I want STI testing, you'll get a plethora of websites that are willing to supply you with STI testing for a fee, of course.
Right.
But to the street medicine point, there are these point-of-care tests.
And Hep C as well.
As well,
point of care.
yes. Locally, we have found the point of care test. I don't know that I should get too into the weeds here.
Yeah, right.
But the point of care test is looking at a syphilis-specific antibody. So if that turns out to be reactive, you actually still need further testing. So you still have to ultimately get what is called an RPR, which
Right.
gives you a serum titer.
And that antibody for the point of care test could remain positive after a previous old infection.
Correct.
Yeah, so it
once,
gets confusing.
Once
Yeah.
someone has ever had syphilis, that antibody test can remain
Yeah.
positive.
Okay.
Yes.
So it's of limited utility,
Yeah.
but
But
yeah.
what I was going to say is our local health department has often used outreach teams to actually do laboratory-based testing that is drawn in the street. And then they transport the blood to our sexual health clinic where we run it, and they have a relationship with the person that where they drew the blood and go back to them in the
Right.
event that it's positive. So it's a one-step process instead of a two-step process then.
Yeah, and that's what we do in street medicine is draw the blood on the street, and then we have to follow up. We have to find people again to give them the results.
Right.
So we've talked about HIV, Hep C, syphilis. Can we go on to then talk about gonorrhea and chlamydia?
Sure. Also, both rising over these same 10 years. I think the thing that has changed with gonorrhea and chlamydia was the development of commercially available nucleic acid amplification tests that were approved for extragenital testing sites. So for a long time, we've had those tests for cervix or urethral testing, but not commercially available, FDA approved for throat or rectum. But they exist now, and that testing is recommended when those sites are exposed to sex, and we find a lot of infections that way. So you asked earlier, could I explain the rise in STIs, and that's one explanation, is we've changed how we diagnose STIs. We look at different sites, and there's a lot of people who might only have throat or only have rectal infection, and if you were only doing urethral, you would say they don't have an STI. So that's one explanation for the rise.
Yeah, I'm gonna ask you now. We've covered the basics. What about the interface between being unhoused and STIs? Is there fresh research out there?
That's a complicated question. There is old research that shows that there is a link, and particularly a link with adolescents, where there can be a high rate of unhoused people with risk and a high rate of STIs among all adolescents. And there's also recent reports that show the overlap of being unhoused and outbreaks among particularly men who have sex with men. And there have been several outbreaks described of different infections. One would be Hep A. Another is sexually transmitted Shigella, causing an enteritis or a colitis. Another is sexually transmitted LGV, lymphogranuloma venereum, which is caused by a type of chlamydia trachomatis. So, but in the evaluation of the outbreak, there have been the discovery that the outbreak is arising among men who have sex with men, and there is also a link with being unhoused. And so somehow the combination of those two things has been seen in several different infections. Several of these have actually been described on the West Coast in the literature. So whether that's because there's high rates of being unhoused in California, for instance, where there have been some publications about this, or just there's a lot of STI research also done on the West Coast.
And it leads me to another question that I don't know if there's any data on this, but the correlation between STIs and substance use disorder. Is that correlate?
Yes, that does correlate in some instances. There's lots of descriptions of substance use, particularly crystal meth or cocaine, and high rates of STIs. And we didn't really get into... Is that
because of risky behavior, like once you're high, or is that something to do with the chemicals themselves?
Probably more often the behavior and having a sexual network where STIs enter the network. and the drugs are also in the network. So,
Yeah.
so you yourself may not have risky behavior, but you're in a network where the organism exists. So it's STI, risk for STIs is not all behavior. It includes background prevalence.
Right.
So if your network has a higher prevalence, you could just takes one sexual encounter.
Right.
But syphilis in particular has had kind of a shift in the demographics. So over the last several years, there's been a shift from syphilis being almost exclusively found among men who have sex with other men to shifting to include a population of men who have sex with women and women. And those groups, the men who have sex with women and women that are newer to syphilis in recent years, there have been several studies that have found an association with substance use, or sort of having your sexual network be a network that has substance use crossover.
Yeah, which is not surprising.
Right.
But tell me about congenital syphilis.
That's
what
another,
are we seeing there?
kind of a sad story that we've had really nationally in New York State and nationally. We've had dramatic increases in congenital syphilis, which is associated with this shift that I just mentioned into the more heterosexual population and people becoming pregnant. It has led to recommendations to increase screening for syphilis among those with pregnancy potential. In New York State, it actually led to a change in the law so that it's now recommended in New York that syphilis is tested for at the time of diagnosis of pregnancy, during the third trimester of pregnancy, and again at delivery. And really, it's been the epidemiology of the cases of congenital syphilis that drove that change in the law, that the state was able to show that even those who were tested early in pregnancy, in the cases of congenital syphilis, had actually acquired syphilis during the pregnancy, or they were in that long incubation period of 90 days when the tests are sort of falsely negative and you're about to have syphilis.
Right.
So that led to this change.
I've never seen a case of congenital syphilis. How does it manifest in the baby, and do we test the babies, and do we treat them with the same penicillin?
Yes. So the most babies that have congenital syphilis actually are asymptomatic at birth. So just like syphilis in the adult, there's a wide variety. So you can have a fetus that develops signs of congenital syphilis. We had a situation where on ultrasound, the fetus clearly had hepatosplenomegaly, had the amniotic fluid was disturbed, so there was definitely congenital syphilis. And with the treatment of the pregnant mother, the baby's abnormalities resolved, and by the time of birth actually was completely normal. So you can have
that's
that
exciting,
extreme.
that you can
that was very
treat the mother
exciting.
and treat the baby. Yeah.
Yes, and that really is the message: treat the pregnancy, treat in pregnancy, and you treat the baby. Any delivery where the mother, the birthing parent, has a reactive test for syphilis, that infant should also be tested for syphilis. And then there's a way to assess whether it's simply maternal antibody that has passed the placenta and the infant is fine, or there's evidence that the infant actually has active infection and requires penicillin. But the treatment of an infant, of a neonate, is penicillin.
Okay. We've covered a lot of ground. We didn't talk about herpes. Is there a word you'd like to say about herpes?
I gave a talk on herpes this morning, actually. So herpes, actually not a lot has changed with herpes other than I was taught, as probably you were taught, that herpes simplex virus, I'm sure you know there's two types, herpes 1 and herpes 2. And the teaching was herpes 1 causes cold sores and herpes 2 causes genital herpes. It turns out herpes 1 and herpes 2 both can cause both. Yeah. It is true that herpes 2 hardly ever causes cold sores, but herpes 1 actually is quite a common cause of genital herpes, and now might be, in some populations, in the young population, for instance, college age and lower, new genital herpes is more likely to be due to herpes 1. Also among the population of men who have sex with men, a lot of new herpes 1. That is not a bad thing because it's a little bit of a milder illness. You're less likely to have recurrences, and the outbreaks tend to be less severe. The other news is that the NHANES study, the National Health and Nutrition and Education Survey that's done every few years. The most recent herpes data comes out of 2015, 2016, but it shows that background prevalence, so the proportion of the population that has herpes 1 and herpes 2 has gone down over time, slightly.
Okay. Like I said, we've covered a lot of ground. What are we forgetting? I'm going to just ask you an open question of, in the terms of sexually transmitted infections, is there something we've missed?
Expedited partner treatment. That is another harm reduction method, if you will. So when you're a clinician, you typically only treat patients that you see, that are your patients, that you have a chart on. You're not supposed to just prescribe medicine for people that are not your patients. But expedited partner therapy is available, I believe, now in all 50 states. It's governed by state law, so what diseases it covers varies by the state. In New York State, you can offer this for gonorrhea, chlamydia, or trichomonas. And it's when you, as the clinician, see your patient who you diagnose with, in New York, gonorrhea, chlamydia, or trichomonas, and then you give that patient either medicine or a prescription for them to deliver to their partner. Now, in the era of electronic charts, maybe you're not actually giving it to your patient. Maybe you're sending it to a pharmacy. There's, again, state-specific rules. In New York, you have to provide a certain amount of education. But then that partner is essentially taking post-exposure prophylaxis for the exposure to your patient who you've diagnosed with those diseases.
Whose name and date of birth is on that second script?
Well, again, that varies by state. In New York, if you don't know the name of the partner, or if, for instance, say the patient doesn't know the name of the partner, it might be a screen name, maybe it's something like that. You put the name of the patient is expedited partner therapy.
Okay.
And then the pharmacist may ultimately fill that out.
Fantastic. You have such a wealth of knowledge. I really appreciate your expertise in these realms. We're running out of time, so we come to our final two questions.
Okay.
We ask all our guests if there were one piece of advice you would give to make the world a better place, what would it be?
I guess I would say what I said to my children is approach the world with kindness. That there's no cost to being kind.
Beautiful. Thank you for lifting up kindness. We all need more of that in these times. And then the last question is, how can our listenership connect with you, or is there a website that you could give them to learn more about your work?
I think the Clinical Education Initiative website, that's CEItraining.org, and that is a website. We offer in-person training to New York State clinicians, but we also have a wealth of online training available to anyone, and I could be reached through that. It's CEItraining.org.
CEItraining.org.
Yeah.
Okay, great. And I have your 800 number on magnets everywhere I go, so you can expect some calls from me. Okay. Thank you so much for taking the time today to talk to us. Okay, bye now.
The opinions expressed in this podcast are those of the individuals included and are not representative of the opinions of the Street Medicine Institute or the Street Medicine Institute Student Coalition. Do not use this podcast as medical advice and instead see your own provider for medical care.